Hello, everybody. We're just waiting for all our guests and attendees to check in, so we'll be starting in a couple of minutes. Okay, well, welcome everybody. My name's Justin Fisher and I'm Director of Brunel Public Policy. Brunel Public Policy is a unit that works across the entire university, Brunel University of London, and its aim is to use our world-leading research to help inform policymakers, legislators and regulators. And we're convening a series of webinars entitled, Are Regulators Keeping Up with the Science? So in this series, we're exploring the latest research from Brunel, which highlights and addresses areas where policy and regulation may need to be updated, and exploring the challenges and issues in so doing. Last week, we held the first webinar of the series entitled, Are Regulations and Government Investment Keeping Up with Agreed Timelines to Meet Net Zero Targets? And a report and a recording of that session will be available on the Brunel Public Policy web pages very soon in case you missed it. It's a great watch. So ahead of handing over the chair today to begin the seminar on the regulation and policy responses to a rapidly evolving major health emergency, I'd first like to highlight the next webinar in the series, which is entitled, Is Regulation Keeping Up with Developments in the Changing Use of Online Digital Communications? Now, this is taking place on Monday, the 13th of January, and registration is now open with a link in the Q&A. I'll now pass you over to our chair, Neil O'Connell, who is a professor at Brunel of evidence-based healthcare. But in the meantime, we do encourage you to ask questions of the presenters, and please enter them into the Q&A section. And you can also upvote questions from others that you would like to see answered. So at this point, I'll hand over to Neil, and I hope everybody enjoys the webinar.
Thank you very much, Justin. Welcome, everyone. It's great to be here today. So let's just set the scene very briefly. The COVID-19 pandemic is perhaps the preeminent modern example in health of where evidence and policy meet in real time and with genuine urgency. The challenges of making and evaluating evidence-based policy at a population level were really never made clearer to us. And I think it's fair to say there are both successes and failures that we can learn from. So I'm delighted today to be able to introduce three Brunel University of London academics who've undertaken critical work in this space, from modelling pandemics to understanding how the public respond to bold policy decisions to evaluating potential interventions. So without further ado, we're going to move into our first talk. It's my pleasure to introduce Dr. Derek Groen, who's a reader in computer science at Brunel University, London. Derek has a strong interest in high-performance simulations, multi-scale modelling and simulation, and so-called VVUQ, verification, validation, and uncertainty quantification. In terms of applications, he's a lead developer on the flea migration modeling code and the flu and coronavirus simulator, FACS, COVID-19 model. So I'm going to hand over to Derek now, who's going to tell us about using the simulation development approach to facilitate pandemic crisis response.
All right, thank you very much for the kind introduction, Neil, and also thank you for allowing me to be part of this webinar. So yes, I will start off talking a bit from a computer science, computational science perspective about using a concept called the simulation development approach to facilitate a pandemic crisis response. Before I proceed, I just want to say that this is not work I've done alone. There are many colleagues in my group as well. For example, Diana Suleimanova, Yanishu, Alireza Jahani, Masihar Gorbani, for instance, who have collaborated this as well as people abroad. Next slide, please. So to start off, I can appreciate not everybody is in the modeling world, of course, as part of this seminar. So I just wanted to clarify first how simulation can help or has helped crisis response in the past. A big important point is that when a crisis occurs, it's usually unexpected. And when there are hints of a crisis emerging, society and all the stakeholders involved, including public health organizations, for instance, they want to know what is coming. Now, specifically in the context of COVID-19, parties, stakeholders are usually interested in when the next epidemic wave would arise and when it will happen, how many people may be affected by COVID-19, which kinds of people will be affected by it. And also they may want to investigate which interventions are effective to mitigate or delay the spread. And if vaccines are available for the strand of COVID-19 or for any other disease, what kind of strategy works best to try and vaccinate people against further infection. Now, if simulations are available in the domain of interest, for example, if COVID-19 simulations or coronavirus simulations were available in 2020, then it's not particularly difficult to adapt them to the crisis at hand and to make change. And I'm going to explain how that could be done. But there are some very important challenges and constraints. The most important constraint is that a pandemic is a very fast-moving phenomenon. So it is essential that any simulation that is used delivers the results in time. You may be able to produce more accurate results if you take more time, but if the results are too late, then any public policy makers cannot use the results to make any intervention. So timeliness is really, really important. And the second part is that it's really important that whatever simulation you've taken and adapted for the crisis response is credible. And credible means that it's robust, of course, and that the results are at least of sufficiently good quality, but it also means that it's transparent and people are able to scrutinize the approach to begin with. And this is often quite difficult in its own right. Next slide, please. So, of course, global crises, like pandemics and many other crises, have an evolution that is rapid and hard to extrapolate. And that's where models could be interesting. And I think before I start talking about an approach to do that, it's good to look back a little bit about, okay, what happened during the first and the second wave of the pandemic? Was it accurately forecasted? So as you may remember, in March 2020, the first wave of COVID really hit. A lot of people were affected. There were a range of models and simulations that were being used to forecast what could happen in the coming weeks. And based on that, the British government at the time enacted interventions to try and mitigate the impact of COVID-19. Next slide, please. So one prominent code that I just wanted to highlight is the COVID sim model from Imperial College London, from the group of Neil Ferguson. This was originally an influenza code, and when the pandemic hit, that code was essentially being repurposed from January onwards to model COVID instead of influenza. So in about 6 weeks' time, they rapidly modified this code to try and address a different disease. They made forecasts, which you can see in the graph on the right side. And what you basically see is the highlighted regions are the solid line is one of the lines is basically the forecast according to the report, and the colored regions are the uncertainty that we have been able to quantify around that original forecast, given the interventions that the UK government has enacted during the pandemic. It directly informed the lockdown strategy in the UK because it made the government aware that potentially a lot of people could be dying if no lockdown measures were put in place. The forecast was also delivered on time. But of course, after the fact, we can run the code, examine it more closely and figure out, okay, was the code accurate? And what we find is, first of all, the forecast had a substantial uncertainty, as you can see by the distribution of the uncertainty on the right-hand side. But also we indicate the actual data, the reality on the ground with the green points. And what you can see is that even though this code seemed very pessimistic at the time and it informed radical policy change from the government, in retrospect, the forecast was actually far too optimistic and the reality turned out to be much worse. The exact reasons of that are numerous and are not very easy to pinpoint, but I think it's very interesting to see that this code actually didn't predict correctly, but still informed very important and useful policy decisions. And I think that's why it's a very interesting use case. Next, please. Next slide. So within my group, we also did work on covering on COVID modeling. We used to do migration modeling, But what happened during the 2020 pandemic was that individual hospitals did not have forecasts about what to expect in terms of intensive care. So we developed a code from scratch called the Flu and Coronavirus Simulator, taking some concepts from our migration modeling code, which would simulate the spread of COVID specifically on a local, on a city or a borough level, and then inform individual hospitals how many patients they could roughly expect during the next pandemic wave. Our code was too late for the first wave, but during the second wave, which took place in basically late 2020, in December, we were able to provide predictions to Hillingdon Hospitals and the London North West Hospital Trust, and we're able to inform them that there would be a considerable peak in cases in early January and around Christmas, so that they could anticipate that in advance. Next slide, please. Okay, now this is all good and nice, but this is just one use case. And of course, you want to look at the general framework work, like, okay, how can we position models and simulations to actually be effective in a pandemic response or any other crisis response? And to look at that, we have to realize that to apply these things, we don't just have to run a simulation. No, we often have to develop the simulation. So to look into that, we basically did research about, okay, what does it entail to develop a simulation in anticipation of a crisis and in response of a crisis? Next slide. So essentially, it covers the following, what you see in the diagram here on the slide, basically. Sorry, let me just... So basically, it encompasses a number of steps, and some of the steps are in the anticipation context. You can do these in advance, and some of these steps are in a response context. So in the diagram at the top, you can see which tasks are required in anticipation and which can be done in advance, and which ones are required to do in response to a crisis. So to just go through it very quickly, in response to a crisis, you need to understand what is the situation, what do you want to forecast, for how long. You need to get the input data, and if available, the validation data. You need to take the model and adapt it, assuming that there's a model there, and add in all the situation-specific evidence, like what kind of strain is going on, is there a vaccine available, what kind of interventions may be taking place, and update the model with that. You then have to update the implementation of the model, the simulation as well. You have to execute that, quantify the uncertainty, how strong can your conclusions be, and then evaluate the result or provide the forecast. But this is if everything is in place. If not everything is in place, you also have to do things in the top box. For instance, create input data type definitions. What kind of data is your generic model going to take in if there's no generic model for it? Develop that model on the conceptual level, so define situation agnostic model. You need to code it up so that you actually have a computer code that implements your conceptual model. And you need to verify that code so that you know that your generic model that you could use in response to the crisis is actually functioning correctly. And in the case of COVID-19, for example, with COVID-Sim, there was a generic model, but it was for influenza. So actually quite a bit of work had to be done in the top box because there was no good dedicated coronavirus model. So an existing model had to be adapted before they could get to the response context. Next slide, please. So by characterizing the simulation development approach and seeing simulation development in these different steps, you can start to estimate how long it takes a group of researchers to actually develop a forecast in response to a crisis. And in our case, you can see here the example for the flu and the coronavirus code. We basically are able to put effort estimates to each of the phases, each of the tasks that we needed to do in response to the pandemic event. So for instance, we spent one day selecting the situation, figuring out, okay, what is the scope of a simulation? 3 weeks to gather all sorts of input data that we needed about behaviors, about properties of the disease and things like that. Then refine the model, refine the simulation, execute it, quantify uncertainty, and make a forecast. Our first forecast took about 1.5 months to complete because many of these steps were not efficient. We hadn't done them before and weren't sure how to do them quickly and effectively. And the slowest steps, the ones that took the most time, are basically highlighted here in red. Next slide. What you can then do as a next step is you can take the individual tasks that you need to do to develop the simulation and you can think about, okay, which ones are the slowest? And then think about, okay, how can you speed them up? How can you automate them? How can you have tools to accelerate them or perhaps just ramp up effort? So what we did is after the first report, we tried to optimize some of these steps in the simulation development approach. We automated the location graph extraction. where you procedurally generated, interventions and things like that. And then after that, after we did those optimizations, we then go through the simulation development approach again, and we can see that the turnaround time is actually a lot shorter and is reduced to only 14 days. What you see here, by the way, is that actually I put the migration model example here and not the COVID example. I do apologize for that. But for COVID, we actually had a similar optimization, and it also was reduced from about 1.5 months to about 14 days. And the idea is that basically by identifying the task within the simulation development approach, we can really do targeted optimization of these individual things. Next slide, please. So that's all I have for today. And I think, just to wrap it up a little bit, by breaking apart the tasks that you really need to do in response for a crisis, you can really see like, okay, what is bogging you down before you actually have to respond to the crisis. And if you're able to optimize those steps in advance, then basically that can help you to estimate, okay, how quickly can we develop the simulation response to a crisis, and basically, prepare the ground for a rapid response. Thank you very much.
Thank you very much, Derek. A fascinating presentation, and it's not lost on me how hearing the words "next slide, please" took me right back to the middle of the pandemic as well. So well done on that too. I should have said before the start that we're taking questions at the end of all 3 talks. As Justin said, please do use the Q&A function in Teams, and you can upvote questions that you would particularly like to be asked while the talks are ongoing. So now I'd like to introduce our next speaker, Dr. Manu Savani. Dr. Savani is a senior lecturer in behavioural public policy at Brunel University of London. Her research focuses on health and political behaviours, applies experimental methods, and draws on quantitative and qualitative data. Recent projects have investigated public attitudes towards remote online voting, voters' attitudes to political misconduct, and how people respond to policies aimed at promoting vaccine uptake. And she's going to be talking today about public attitudes to pandemic policies. Thank you, Manu.
Thanks very much, Neil, and hello, everyone. I want to talk today about public attitudes to different policy approaches applied during the pandemic to change our behaviours, contain the virus, and strengthen public health protections. My argument is a straightforward one, that the pandemic revealed we are more accepting of restrictive policies than we previously expected, and that this gives us food for thought for future policy making. I'll make this argument drawing on publicly available opinion data collected by polling firms like YouGov and from research data that I collected, including as part of a team funded by the British Academy. One of the fundamental questions when faced with a crisis like a pandemic is, how should governments intervene? How much intervention? How intrusive should policy be in our lives? Policy options can be understood on a spectrum of persuasion to coercion, soft or hard policy measures, or another way to put it is on a spectrum of low to high stringency. A high stringency policy would mandate change and raise the costs of non-compliance, for example, a ban, a mandate, strict requirements on movements and socialising. A low stringency policy would encourage change and have lower costs of non-compliance, for example, an informational nudge or a text message reminder. During the pandemic, we saw a whole range of policy measures on the spectrum from low to high stringency. We saw information campaigns, which did not force us to do things differently, but certainly reminded us of the guidelines in place and appealed to social norms and emotions to encourage us to keep following the rules. At the other end of the spectrum, we had stricter rules that told us where we could go, when we could leave home, and who we could see. The received wisdom is that people like policies that encourage and persuade rather than coerce. They like information and nudges. Studies comparing attitudes towards different public health interventions found that support was generally higher when the intervention was perceived as less intrusive. For instance, people preferred warning labels over sin taxes. Meanwhile, nudges have been found to be broadly acceptable in many countries. Then COVID-19 comes along, and the evidence seems to be suggesting something else. People are seemingly ready for more stringent policies than we had ever had, and even more stringent than government were actually implementing at the time. So, for example, 93% of British respondents supported the initial lockdown measures. Many of them believed that lockdown should have been for a longer period. The following year, 85% of people supported the winter 2020-21 lockdown, and many of them believed it should have been introduced earlier. This seems to be at odds with the received wisdom of behavioural scientists who were concerned about behavioural fatigue in response to restrictive policies. Was this just the UK? No. International evidence chimes with this general trend. The chart here shows high levels of public support for lockdown measures in countries from Italy to Singapore. Even in the US, where we might expect pushback based on libertarian arguments and distrust of centralised government, research found that policy measures like mandated face masks on public transport were broadly supported across every state. Other research on Australian public attitudes offers some fascinating insights too. One study asked members of the public to choose between policy approaches that used different degrees of restrictions, tracking, duration of lockdowns, which were set against the potential policy outcomes of infections, death, and economic outcomes. In general, people prioritised the avoidance of infections and death, and there was a clear willingness to trade off personal freedom, to accept higher taxes, and to preserve public health. That study also challenges fears of lockdown fatigue. Another way of looking at this is to ask people about their underlying values which might drive public support. This table presents responses to a survey question that asks if respondents agree it is important to save lives over preserving liberty. This is to get a sense of whether stringent policies for public health might be valued more than less stringent policies that restore personal freedoms. And we see here that the majority of people give an agreement score of 5 or more out of 10. A minority of people rate liberty over life, and that's pretty consistent across the G7 countries. Was this just a 2020 thing? The initial uncertainty and fear of the unknown virus triggering a risk-averse response from the public? To some extent, yes. Looking at trends over time, it's fair to say that public opinion can and did vary, but not in a linear fashion. Once support for a particular measure started to fall, it could rise again in response to the COVID-19 situation. Support for some measures fell and then reverted to higher levels when perceived and actual risks increased. For example, the winter of 21-22, which corresponds to Q5 in the charts there. Going on from there, in spring 2022, when members of the public were asked if they would support or oppose reintroducing stringent policies like mandatory self-isolation or being required to wear masks indoors, the majority of British adults said they would tend to or strongly support this. It was a sign that the public were not experiencing behavioural fatigue and were ready to comply with stronger restrictions for longer than we might have initially expected. And what do we learn about when people are more likely to support stringent policies? Recent evidence suggests that individual and country level experiences, age, and political attitudes can all play a role. Perceptions about how effective the policy is also matters. I tested this in a study about a hypothetical booster vaccine. When it was expected to be more effective at conferring public health protection, respondents were more likely to accept more stringent vaccine promotion policies like employer mandates and tax breaks for the vaccinated. There was a threshold effect, however, so people do not accept stringent policies without limit. Beyond a certain point, it appears that the appetite for trading off freedom for public health starts to flatten off. Before I close, I wanted to present a final couple of charts. This is very recent public opinion snapshots from just last month. The question posed was, in retrospect, were the lockdowns the right approach to contain the virus? And the data suggests the majority of people thought lockdowns were the right approach. These, of course, are averages, and the more interesting question is what individual characteristics underpin these averages. So to give you a quick sense of this, I've broken the data down by age and by political party affiliation. So we can see here that the youngest respondents were actually most supportive of the stringent policies, followed by the oldest, slightly lower levels of support in the middle age groups. And there's a pattern when we look at politics too, with higher than average support among the Lib Dem and Labour Party voters, and considerably lower than average support among Reform voters. So what do we learn? Public support for different kinds of policy measures on a spectrum of less or more stringent does not necessarily follow the expected patterns. It's not always true that we prefer nudges over harder policy instruments like mandates or bans. When policy challenges require trade-offs between social, health, and economic gains, there is nuance in people's choices and evidence that personal liberties can be traded off in favour of public health protections, for example. Going forward, policymakers should also be open to nuanced policy decisions, even bold policy decisions, and allow for the possibility that the public are willing to accept tougher measures. The pandemic gave us lots of evidence and insight on these issues, but we still need to gather more evidence, particularly on understanding whether the experiences of the pandemic have changed the way that we accept policies now, whether that's to do with public health still or with other pressing challenges as well, like climate action. So I'll end there just to share some acknowledgements. Lots of the research that I talked about there was done with all my co-authors listed there, and some of the resources that I've kind of used there can be found online as well. Thanks very much.
Thank you very much, Manu, for an excellent and thought-provoking talk. Just to remind everyone again, we welcome questions here, and please do use the Q&A function and we can select from your questions for the discussion at the end. So moving on to our third and final speaker, Dr. Fotios Drenos. Dr. Drenos is a reader in genetic epidemiology with an interest in computational medicine and the statistical genetics of complex common diseases. He has led and contributed to a number of research programs examining the genetic basis of the risk factors for cardiovascular diseases, diabetes, and cancer, integrating information from rare mutations and common genetic changes. And today he's going to be telling us about rapid evidence for the use of vitamin D against COVID-19. So thank you very much. Over to you, Fotios. Oh, you're muted.
I know that's what happened. So thank you very much. And today I'm just going to quickly describe the work that we did on vitamin D during the COVID pandemic. So vitamin D is actually a hormone. We know about it for 100 years now. We know that it prevents rickets, and it is involved in bone metabolism. Lots of people suggest that it does different things, and the problem is we don't know that much. So vitamin D, we can either take it through supplements, the picture here, or through our diet. Fish is a good source. Or actually we can make it ourselves with exposure to the sun. So before I go to vitamin D, imagine this situation. We have a new intelligence coming into Earth or emerging in Earth that wants to help us, right? This is a picture from a Netflix series called Love, Death and Robots, where yogurt takes over government of Earth. So imagine that we have this kind of new intelligence and they want to help us, but they don't know anything of what we're doing. So they're trying to collect data. So one of the major causes of death for young people, right? We're talking about 1.2 million deaths per year, which is comparable to the deaths that we saw from COVID in the first year since its emergence, so mid-December 2019 to mid-December 2020. Are traffic accidents. Actually, this week is the week for road safety. So we do know that has a huge impact. So we have this intelligence that want to sort out this problem, help us solve this, save 1.2 million lives a year. So what will they do? Well, probably they'll put lots of sensors in the car trying to understand what we're doing. And if you see what we're doing, people have done this already, you see that before an accident, so the frequency of an accident you see at the top, someone is usually braking hard. And you see that there is a very good correlation between days where people crash and days where people actually brake hard on their journeys. So what will an intelligence make of this? Well, they will say, all right, since the two are correlated and the event of braking happens before the crash, then why don't we take brakes out of the cars, right? So that should fix things. But yeah, if it is an intelligence, it will understand that this doesn't work. And of course, that's an extreme case of a fallacy that we do very, very often, especially when we're discussing public health policy and interventions. The problem is that we confuse correlation for causation. In epidemiology, it's important to understand causation, because causation ensures that if we change A, B will change. So if we change the risk factor for a disease, the disease will, we will prevent the disease. Correlation means that, yeah, these two happen together, but it's not guaranteed that by changing what I see correlated will make any change to the disease. And it is a very subtle difference between them in many, many cases. And actually, that's what we saw in the early days of the pandemic. Vitamin D was suggested as a way to boost our immunity. And then all this kind of news articles came out and all these big titles saying that, oh, you know, 80% of those that go to the hospital are vitamin D deficient. So they have vitamin D, which is very, very low. And they say, you know, if you go to the hospital and you are vitamin D deficiency, you are very likely to die. Or some people even put it further on, that they just start describing that doctors from with an African ancestry that had darker skin were dying due to vitamin D deficiency. In the middle of this, there was a study, a Spanish study, that was saying, oh, we gave vitamin D with people and we stopped them from dying. The problem was that this study was investigated and we found out that actually what they described and what they did is not the same, and it had issues, so this was retracted. The same as this study that was saying about vitamin D deficiency and dying in ICU, in intensive care unit. And the problem here was that the people that did it didn't control for all the potential covariates, the potential confounders. Of course, the guidance from NICE, the National List of Care Excellence, stayed despite all these things emerging about vitamin D. It did stay as it was before, saying that vitamin D is not a recommended way to prevent COVID, either contracting COVID or COVID severity. So why is the problem in this case in terms of vitamin D? Vitamin D tends to be very low for people that are indoors. And people that are indoors are people in nursing homes, right? So you see here, nursing home residents have 42% vitamin D deficiency. We also saw that these that are older also have low vitamin D. So of what we know now, lots of the early deaths in the pandemic happen in the nursing home in older people. So unless we can control effectively for this, our results are not going to be reliable. We also saw that those that were dying from COVID very early on were people with obesity, right? People with excess fat in their bodies. And this wasn't taken into account either. So we need better evidence. And what kind of evidence do we have in epidemiology? Usually we have observational evidence. So we observe what happens to the population, but we don't intervene. We just see. And we're trying to use statistics to make conclusions of what we see. The best and the most common way that we can change and assess causality in epidemiological sense is the randomized controlled trial, which is an experiment. And this is what is used nowadays for drug development. And this is the necessary step in drug development before we release the drug to the market. And of course, one randomized controlled trial is not the answer. Usually, you see randomized controlled trial is halfway there, then we need to have lots of them. So then we can do systematic reviews to provide a very, very reliable answer to what we say. But during this kind of first days of the pandemic, where there was lots of observational data, but no randomized controlled data, no causal evidence there was lots of pressures from both main political parties in the parliament to provide vitamin D to everyone. The problem, it's not that they were saying give vitamin D. I mean, vitamin D for most of us is quite safe, but that's not true. We can have too much vitamin D. It can lead to vitamin D toxicity that has both short-term consequences to health and longer-term consequences, especially in kidneys and heart. The other problem is that if you say to people that, all right, take vitamin D, we give you vitamin D, you're protected, then you change the motivation and the behavior of the individuals there. So you tell them that you have already gave them something that makes them safe, so that they are free to take their chances. And if what you give them is not truly protective, then you're actually exposing people to greater risk. So how would causal evidence work in this case? So we'll take, let's say, 1,000 people, and we will split them into two groups randomly. Half of them will give vitamin D supplements, and half of them will give a placebo. So something that looks like the vitamin D pill, but it doesn't have anything. Then we will measure if that works. So we will measure the vitamin D just to make sure that, yeah, those that we gave the supplement have higher vitamin D. And then if vitamin D is protective, then we will see that the intervention group, the one that got the supplement, will have less COVID-19 and lower severity. Of course, to get 1,000 people, give them vitamin D, make sure that we follow them long enough to be exposed to COVID-19 sufficient terms so we can check what's happening, takes time. And time is not what we have in these kind of cases. So there is an alternative now using genetics. So what happens is during conception, we inherit the predisposition that exists in our parents in a random way, right? And it is random not only to what our parents had, but it's also random compared to other things. For example, it is random compared to what our parents did for a living, how rich our parents are. All these genetic predispositions are inherited separately, each of them. So what we can do is then treat this predisposition, this inheritance of the predisposition, as a randomization factor. So we say that either you get higher predisposition for vitamin D or lower predisposition for vitamin D is not affected by if you are obese or what is your socioeconomic level, which had an effect in COVID-19, both contracting COVID-19 and severity. And of course, because it's genetics, it stays the same throughout our life. So it will stay the same either if you're 5 or 85, right? So at 5, if you have higher predisposition for higher vitamin D, you will have higher vitamin D than the rest of the 5 years old. If you are 85, you will have higher vitamin D from the other 85-year-olds. And then you can check if now these people with higher predisposition for vitamin D or higher predisposition for deficiency in vitamin D, so low vitamin D, are more or less affected by COVID-19. We did this and we found that there is no evidence to support this idea. So predisposition for someone to have higher or lower vitamin D didn't affect the risk of COVID-19. So the key here is how rapid we can do it, right? So it took us a day to find the genetic predispositions for vitamin D deficiency And we did know already genetic predisposition for vitamin D levels, and it took us 1 day to do both the deficiency and confirm the information we already had. And we used the UK Biobank on this, which is a study throughout the UK, having 500,000 people that do have genetic data. And we used, for the outcome, for the COVID severity, we used a meta-analysis of 17 big studies, large studies across the world. So when pandemic started, the bigger genetic studies combined their data, and on the 2nd of July, this is the version that we used, we had around 1.5 million people covered, and for them, over 6,500 cases of COVID-19, around 1,000 hospitalizations. So 1,000 people is a fair amount for a randomized controlled trial, and we managed to have this very, very early on in the pandemic. So this was released in July. So they did the analysis in June. June 2020 was less than 6 months since COVID started to spread away from China. So we did the work mid-July. So by the 29th of July, we were able to present our data in a meeting organized by the Ministry of Health in Bahrain with the British Embassy, where we provided evidence on what can we do to fight COVID-19. And we actually submitted this a week later. So it took us 2 days to do the work. In a week's time, we're able to present it, affect policy in Bahrain, and submit it to the BMJ, so the British Medical Journal, Nutrition, Prevention and Health. The problem is that these kind of things do take time to be peer-reviewed, and peer review is an important step. So we had to wait till around Christmas when it was accepted, and it was accepted on the next day. It was available for people to see online as peer-reviewed and as a reliable resource that other peers have seen. We had to wait till the 30th of June to actually have it as formally published, but it was available from Christmas 2020. So with the help of Justin and Brunel, we were able to submit this as evidence to the UK Parliament, and we just managed to do it on time because it was the time when this idea of giving vitamin D to everyone was discussed, and our arguments were mentioned there, although we're not cited, by Joe Churchill, talking on behalf of the Health and Social Care group, and she was saying about bias and confounding, and that causal relation between vitamin D and COVID-19 is a crucial part that we need to think. And I think, and the take-home message, so please remember, especially for policy, not all evidence is equal, and if we want to do an intervention, then we do need evidence for causation. Although sometimes we say we can do it and then worry about this, please remember that all interventions do have unintended consequences, especially medical interventions. And actually, we do have existing data that we can rapidly use to provide, if not the same level of evidence as a randomized controlled trial, something which is comparable. And despite the delay of the process, peer review is important. So thank you very much.
Many thanks, Fotios, another excellent presentation, which brings us into a little bit of time for questions and answers. I can see in the Q&A chat that we have a few questions. And so I'm going to direct my first question to Derek. And Derek, someone's asked, are people using these sorts of crisis simulations that you were talking about for anticipating and managing quite different types of crisis from this health crisis of the coronavirus?
Yes. Well, the interesting thing is, I think simulation often been used in times of crisis, but people don't always tried to characterize how long it takes to respond. The crisis hits, they prepare the simulation, they rush things, and either the simulation is bad or it's not in time. So it's always been very ad hoc. And I think the idea of this particular research in this paper is to try and be more structured about anticipating the crisis. But yes, there are definitely other domains where crisis anticipation and response is taking place, and also domains where it's very mature. So a very simple example is hurricanes. So hurricanes, there are dedicated centers with dedicated supercomputers where they anticipate hurricanes forming, moving, intensifying. They account for uncertainty. The simulations are accurate and in time, and they've got it really sorted out very well. An area that I'm active in is migration. So in the case of migration, there tends to be less budget. We don't have a dedicated supercomputer, but there are reports that we have written, for example, in the context of Ukraine with UNHCR to try and quantify, for instance, what are the effects of Russia bombing energy infrastructure in Ukraine on the migration patterns within Ukraine. Would we get more refugees or internal displacement? And there's actually a report or presentation that we gave in September in support of that project. So yes, there are definitely other situations where this simulation development approach, these kind of responses are useful and required. But there are also many situations that have not been explored yet. And especially small-scale violence is something that has not been explored much with simulation, also in part due to the ethical implications, which can sometimes justifiably complicate things. Thank you.
Great, thank you. And just to keep you on your toes and bring you back to coronavirus, in terms of these models and as you're building them, are there any important parameters that are missing from the models, and are there solutions to that? So what I'm thinking about are the kind of known unknowns, the things that we know might be important but are hard to measure, and we haven't got good data to put into those models.
Yes, and again, there's the ethical dimension a little bit with that as well. There are two things I think that I would highlight for this. I could name 20, but I'm naming two. The first one is compliance. So during the lockdown and during 2020, the information on compliance rates with the lockdown measures has been very, very small, very low, very hush-hush. At some point, there was one sentence in one official SAGE report that said, oh, compliance may be as low as 50%, and that's it. So then we have to make a simulation assuming how many people are wearing masks in a supermarket, right? How many people are actually keeping their distance? Are they keeping their distance, not their distance, a smaller distance? What are they doing? There's no information collection on that. It was very, very poor. The other thing that was quite interesting is we developed our simulation from scratch. So I also got acquainted with the epidemiology modeling scene. And one thing that was very interesting was this notion of an R naught, or kind of a reproductive rate of infection. So essentially what a lot of modelers were doing was they were sort of putting the rate of infection into a model to then predict the rate of infection that comes out of the model. And the interesting thing is that this quantity, this R0 quantity or R naught, would not be pinned down to a specific experimental setting or situation, but was rather like, oh, well, how fast the virus spreads in a general setting. So that is something we did different in our code. I'm not sure our code is more accurate, but at least it did break that dependency. So those were two factors that I think could warrant a lot more research.
Great, thank you, Derek. Our next question is for Manu, which is, do you think your results point to a wider pattern that citizens are often much more authoritarian, sometimes alarmingly so, than policymakers?
Yeah, it's a really interesting question. I mean, it would seem to kind of hint that way, but I would look at it slightly differently. So rather than describing it in terms of a political ideology or with kind of language around authoritarianism, I'd say that what it's suggesting, the data suggesting, is about our trade-off behavior. When we're faced with a trade-off, we are more willing to prioritize our health, for example, over things like personal freedoms. So I think it's telling us something about how we approach those trade-offs, how much of our freedom and for how long we are willing to kind of give up in favor of some other desirable outcome. So I think that's what it is. Yeah, that's how I would see it.
Great, thank you, Manu. And you mentioned climate change as a sort of potential thing that you might use these methodologies to understand. And I was thinking, in the kind of immediacy of the coronavirus pandemic, where we were all close to people that were being touched to it, I can see how, these results, have spun the way they have. But with climate change, often, particularly in the West, our personal impacts are quite small. Do you think that will play much of a part?
Yes, I think there's a few things there. Climate change is a really interesting case, and I think it is genuinely is to be researched whether some of the behaviours we saw around public health can actually be applied to climate change behaviours. So some of the things that might matter are things around your own personal experience. So if you have seen what you think is an example of climate change in your own personal life, if you've been affected by it particularly negatively, then you may be more willing to think about, well, what are these measures that we need, not just for myself and my behaviour, but for everyone. In a way, what could be happening there is by demanding or by being willing to accept these more stringent policies, perhaps this is almost trying to apply a kind of commitment device for your whole community. It's not enough if just I do X, Y, and Z at home or with my transport choices, but if everybody has to do it as well, then maybe we start to see some change. There could be some interesting issues around that. But I think the immediacy of when we experienced COVID and the kind of day-to-day things were changing, new evidence was coming out, there probably was something there that meant it was a bit easier to apply these kind of stringent policies. People have present bias. When we see the costs of something immediate now, when the benefits are in a kind of unknown, distant future, we tend to prioritize, well, what do we need to do right now for ourselves? So in a situation like that, which really does affect climate change policy, it's not as clear whether we are willing to make the same trade-offs.
Thank you very much. A question here for Fotios now. Regarding your vitamin D study, what are the best ways of achieving equitability with the Mendelian predisposition-based approach?
I'm not sure what equitability refers to here, but what we did with the predisposition, well, it's very simple to do, but still is not randomized controlled trial. It can point you towards a randomized controlled trial, and we have many, many examples now from drug development where it works. And what we usually see is that if you don't see an effect by your predisposition study, it's unlikely that you'll see an effect of the drug later on, which is what we saw for vitamin D actually. And still there are no large randomized controlled trials suggesting that vitamin D is actually good for you or can be used against COVID-19.
Great, thank you. And coming away from the methods a little bit, but staying on vitamin D, and then this will be a personal opinion I'm asking for really, but what do you think was driving this sort of push to oversell the potential of vitamin D? Do you get the sense that it was commercial interest largely from the supplement industry, or more optimism, superficial plausibility, and a bit of clutching at straws?
I think people saw it as something which is reliable, something which is available and safe, which is not the case. You can have too much. And I think it is a problem with vitamins in general. It's not only vitamin D, it's vitamin C, all vitamins. I'm not sure why they are marketed so much. We still know very, very little on what they do, although they are around for some time. It's just something that has been imprinted in us for many, many years, and we still go on and we say that this is health, which is not very well supported.
Yeah, and there's a lot to be said for the something must be done bias as within that, I'm sure. I don't think I can see any. Oh no, we have one more question. Do we have time for another question? Just asking the moderator. It sounds like we do. So let me just check in the Q&A here. This is a question for Manu. Are there other examples where people have accepted more stringent measures? Oh, sorry, there's not a question. It looks like a statement. Let me just open it up. Other examples where people have accepted more stringent measures are smoking bans, plastic bag charges. Do you know what contextual factors might influence whether and when people are willing to accept more stringent measures? I think you've touched on that a little bit in your previous response, but anything you would add there?
And I think we can think about it as there are individual level characteristics, so age, personal experiences, the direction in which your self-interest might go, particular behavioural biases that you might exhibit. But there are contextual ones as well. So the political system you're in, what are the political and social norms? What are your expectations of how others will behave and perceive it? So there is a whole raft of things. It's not as easy as just picking one or two key ones depending on the behaviour. But I think the two examples that are given there, both the plastic bag charge and the smoking ban, are interesting. With both, particularly the smoking ban, there was perhaps a little bit more hubbub in the run up to it. But once it was in place and it became normalised relatively quickly, I think exceeding most people's expectations, it then became the new status quo and people got on with it. And I think that's the thing that we might underestimate. Something that seems quite radical, once it actually is something that we've experienced, we might be more willing to accept it. It's a bit like the Overton windows kind of moving once we see how does this work and how does this feel to live in this new policy environment.
Great, thank you. Oh, it looks like there's another question. Let me just see if I can find it. I can't see that question, I'm afraid. Let me scroll down. Yeah, I'm afraid I can't see that question on my screen. But I did have one more question, again for Manu, which is, you know, looking at how politics has shifted since the pandemic and potentially a move towards greater polarization. And it seems to me that views around some of the health measures align with potentially party political or ideological views more. Do you think that would influence how the public might react to a future crisis, similar future crisis?
I think the political discourse and norms definitely are important. We've heard, lots of things about kind of nanny state politics. You can probably apply that to many of these stringent measures because, after all, the government is taking a stronger step into our lives to kind of try and change the way that we behave. Whether the politics will change enough, I'm not sure. I suppose it's to be seen. You could argue that we'd had a lot of that in the years running up to the pandemic, and yet people were still willing to accept some of these interventions. But I think it's something that we definitely need to keep an eye on.
Great, thank you. And we do have one more comment, and again, it's for you, Manu. So we're making you work this afternoon. But the comment here is that citizens often use common sense based on their own day-to-day experience, much more, sometimes alarmingly so, than policymakers who might be more worried about their future prospects of voting out if they got it wrong rather than about the situation at hand. Do you have any views on that?
Well, I think that the question's right to say that we do use our kind of day-to-day experiences, call that common sense, or what we're observing around us. Whatever we look at from the outside, something might look irrational or present biased or some other biased, but actually moment to moment, it might seem rational for that individual at that time. I think does the question have a little bit of criticism about government policy making? I'm not entirely sure, but I guess that the common sense aspect is definitely part of it. Yeah.
Great, thank you. Well, that comes to the end of our time for questions. I want to take a moment to thank the audience for their questions and thank our speakers for 3 excellent and informative presentations. I think I'll be handing over now back to Rosie from the Public Policy Unit for some closing remarks. You're muted, I think, Rosie.
I think, can you hear me now?
Yes.
Right, great. So yeah, thank you all. Just a quick, so I'm the manager of Brunel Public Policy, and we decided to convene this event series on our regulators keeping up with science, because we think there's so much exciting and relevant research here at Brunel that can have a positive impact on policy making and regulatory processes. So I think there was a lot raised in that area today and in our last session. So just to let you all know, you can see we'll have reports and recordings available very soon on our website if you want to look back on today or at our previous one from last week. So and finally for today, just to say a big thank you to our speakers. Derek, Manu and Photios for providing really thought-provoking talks that highlighted the range of ways in which current research could support policy and decision-making in health crises such as a pandemic. Thanks also to Neil and to you all, the audience, for helping us to explore all of the issues raised, especially around what we learned from the immediacy and severity of COVID, in terms of the measures that people will accept, the quick, easy treatments that they might want, and how we might plan for future such crises. So thank you all, and I hope to see you all again at our next event in January. Link again in the chat, in the Q&A for that. Thank you all.